Okay, we're still going to give folks a few minutes or a few moments to trickle in. And this is being recorded in case anyone wants to watch anything back or don't feel like you need to take furious notes or anything like that on this Friday afternoon. But we have a pretty exciting conversation for you guys today. I know newborn screening is a hot topic both on the statewise and for the RUSP. So we're excited to chat some more about it. And we have some great speakers here with us today, and I'll let them introduce themselves when they're up to talk. But with that, I will pass it over to our friend. Oh, wait, no, I think we're going into our agenda first. Emily, would you mind going to the next slide? Thank you. So in this, we're going to do an overview of newborn screening. Annie's going to give us a little bit of the background and history on how we got to where we're at now. Then Paul is going to give us a RUSP ACHDNC update about the status of our federal package. And then Jill and I are going to talk through some of our next steps with our short and long-term goals and how you can help on the state and federal level. And then we will have a question and answer section. If any questions pop up during the webinar, please feel free to type them into the chat box, and then we can take them at the end, but you don't have to wait until the end to ask a question. Like, please send it whenever you want to, and then we will wrap. So with that, we can go to the next slide, and I will pass it over to Annie.
Hi, everybody. So first of all, thank you so much for inviting us all to be here and for joining us today. This webinar has been a very long time in the making, actually probably almost 15 years since we first started as a community talking about newborn screening for Duchenne and working on newborn screening for Duchenne. And I'm really thrilled to get to help provide a little bit of context with these wonderful partners who we actually have all been working collectively together for that time on this effort. So to start us off, we want to provide a little context around what newborn screening is in general. So not specific to Duchenne, but what are we talking about when we talk about newborn screening? Because many of us have actually experienced newborn screening, but may not even have been aware of it. So we first want to provide that context. And then we're going to talk about how we've prepared for this moment for Duchenne specifically. So let's first dig into the following questions. What is newborn screening? Who is screened through newborn screening? What does it screen for exactly? When does it occur? What is involved in the process? And then if throughout the process you receive an out of range or a positive screen, then what happens next? So that's what I'm going to cover. And then I'm going to tag over to Paul, who's going to talk a little bit about the process that we're involved in right now in order to nominate Duchenne as a condition that we believe very strongly belongs on the universal, the federal newborn screening panel, which we'll talk a little bit about. So first, let's start with what is newborn screening? So when we're talking about newborn screening here, we are talking about a public health program. So we are talking about a public health program that identifies babies who are born as having a risk of a serious health issue. And I think it's important that we distinguish between a screening test and a diagnostic test, because what we're talking about is creating a paradigm shift in Duchenne right now. So right now, probably most people who are attending this call or are part of the Duchenne community, most of the community right now has entered the community because your child had clinical symptoms of Duchenne that you recognized, and you entered the system through diagnostic testing. So you had testing performed after your child had symptoms and you were looking for a diagnosis. What we are going to be doing is sort of flipping that script around. And we are going to be conducting screening testing. So newborn screening helps identify a condition prior to the onset of clinical symptoms. Screening tests do not confirm a condition. What they do is they screen as to whether or not somebody should be moved on for diagnostic testing. So you can think about screening testing that happens in the school system for hearing and vision tests. We have screening testing for cholesterol when you go to the physician. So again, those tests that sort of flag whether or not something might be out of range, but then you have to do the follow-up for the diagnostic test to get a confirmation. So that is what we're talking about with newborn screening. So let's go to the next slide. So who is screened? So already all babies who are born within the US healthcare system and born within a hospital are already screened for select conditions that have been determined to be serious, yet treatable, and present in childhood. And that is the criteria for the Advisory Committee on Heritable Disorders in Newborns and Children. So that is that snazzy acronym that Lauren used at the beginning, that ACHDNC. And that is the criteria that is considered for whether or not a condition is added to the federal panel. If a baby is born outside of a hospital, so a home delivery, there is a birth plan that is created in order for that newborn to receive the newborn screening. So the next. So if you had a baby here in the US, your child received newborn screening, and your child received newborn screening for 3 different types of screening. Your child received a hearing screen, your baby received a heart screen through pulse oximetry, and your child received screening for a number of conditions that have met that threshold for criteria for the federal RUSP through a heel stick or blood screening. So for the purpose of the rest of the conversation today, we're going to focus on the conditions that are on what we call the newborn screening card through the heel stick, because that is the mechanism through which Duchenne would be added for screening. And if you're interested in a list of all the conditions that are screened for, you can go to, we put a website here, Baby's First Test, which is a website that is managed by one of our partners who has actually been working very closely with us on this process of developing the infrastructure for Duchenne newborn screening, and they maintain a very nice updated website. So let's go to the next and talk about when this occurs. So again, if you had a baby, you may not even remember the first 24 or 48 hours after you had your newborn, but that's when that screening occurs, and it's time sensitive, and oftentimes you don't stay in the hospital beyond that time period anyway, but that's when it first happens. And the conditions that are included on these state panels, so they've gone through the federal recommendation, and then there's a second level of adjudication at the state for the state to then add a condition to their panel. And again, Jill and Paul are going to talk about that a little bit more. But the point I want to make here is that these are conditions that the public have met a public health standard for compensatory screening, and they are not consented. So you have the baby, and this is a part of the health screening and health processes that occur in the hospital. Now, there are other conditions that might be being piloted in your state that are still under research for whether or not these are conditions that are ready to be added to a panel. And if there's any research happening in your state, a genetic counselor or a nurse might come in and ask you whether you want to participate in that screening program, in which case you would have to provide additional consent for your baby to participate in that screening program. That's separate from what we're talking about here today. We have conducted newborn screening pilots through consented programs of Duchenne, and we have determined through those programs that Duchenne warrants being added to the public health program. So what we as a community are now moving forward are recommendations and requests to a federal advisory committee and to the state advisory committees to request that Duchenne be added to these compensatory screenings. So I just want to flag that what we are now moving forward is that Duchenne be added to the screening panels that are done automatically when babies are born. Okay, next. Okay, so the process is a heel stick. So babies already, because there is a list of conditions, there are right now 37 conditions that are federally screened for, and then some others that are screened for in select states, that babies have, there's a dry blood spot card and there's an image of that card, and there's a heel stick. Babies probably don't feel it, and I'm sure none of us remember that happening to us when we were born, and a spot of blood is added to that card. And what we are advocating for is that there will be a punch taken out of each of those dots on the card, and that one of those punches be used. So almost think of like the old-fashioned hole punch, single hole punch. One of those punches be used as a sample that then would help screen for Duchenne. Once that's done, it's collected in the hospital, and that card is sent to the State Department of Health for analysis. And the State Department of Health then runs the analyses on all of the conditions that that state has determined they screen for in that state. Next slide. Okay, what happens then? If a screen is out of range, then the family and the family's healthcare provider are notified. And they're just notified that one of the screens that were conducted was out of range and needs to be repeated. Because remember, this is just a screen. So we're not at a point of providing any diagnosis. We're just letting somebody know that the screen was out of range and we need to reconduct it. The State Department of Health has specific guidance on each of the screens for each of the conditions that they conduct to provide a little more information about what that screen was for. And it's specific to each of the screens that they're conducting. If the screen was within normal range, because remember, we're screening for a lot of different conditions, no follow-up is done. So probably everyone on this call didn't get a phone call back. And those results get recorded, and the dry blood spot cards either get stored within the state health department for a specified amount of time, depending on what the state legal requirements are, or they get destroyed, depending on the state legal requirements. And every state has different laws around how those cards are managed and stored. So we're now going to start to focus on what happens if there is a positive screen. So if that screen, if once that baby is born, that baby has an out of range result, what happens? All right, let's keep going. Okay, so in Duchenne, what we have done as a part of this work is we have done a lot of work to validate a CK specific to newborn screening. So again, because this is the Duchenne community, everybody here is absolutely expert in Duchenne. And what you know, as soon as I say the word CK to you, you know that CK can also be flagged, not just because your muscle enzyme is elevated, but sometimes because your liver enzyme is elevated, or you can get a lot of false positives out of your CK. However, as a part of the work that we have done as a community to prepare for newborn screening, we worked to develop a CK that is specific to muscle, the muscle enzyme, and that is the CKMM. And we worked with our partners to validate that CK test. We worked with PerkinElmer, the California State Department of Health, and the clinical sites and centers in California. And if you're a family in California, you may have actually been a part of some of this work with us to develop a FDA-approved CK kit that could then be a part of the newborn screening process for Duchenne in the US. So that is what we're talking about when we talk about CK for the purpose of newborn screening in Duchenne. It is very specific. So if that CK is positive or out of range, it is then repeated. And if it is again out of range, and through our pilots, we have worked very hard to develop a CK threshold that we believe indicates for Duchenne and not for Becker and not for other neuromuscular diseases, because what is being moved forward is a recommendation at this point for Duchenne. But if it is out of range, then a recommendation is made for genetic testing to be conducted. We have also worked very hard as a part of this infrastructure effort to develop resources for the providers and the families that will provide information about what this out of range result could potentially mean or what it may not mean, but so that families aren't just left in the dark at this point. And again, we are aware that most primary providers don't know Duchenne. So we've worked with the American Academy of Pediatrics, PPMD, MDA, the American College of Medical Genetics, to have materials for providers and families to talk about what Duchenne is, and specifically what Duchenne is for a little guy, for a newborn. And so those materials are available on MDA's website, PPMD's website, through all of our partners, and have been put together as clinical kits, but they're also available through our state health departments as well, and are being pushed out by partners. If the genetic testing confirms Duchenne or rules out Duchenne, but still flags the potential for another neuromuscular disorder, then a referral is made to a neuromuscular expert for follow-up. So all throughout the system, what we've been doing all along is working as hard as we can to make sure that if a family with a newborn is identified as having an elevated CK, that family is referred to their pediatrician, their primary provider, and then to a neuromuscular expert with resources that will help answer questions that they may have along the way. The other thing that PPMD has done in partnership with MDA is work to develop clinical care resources for babies who are receiving a timely diagnosis of Duchenne. And over the last 10 years, there have been multiple meetings in partnership with CDC and our clinical experts who've been treating children who've been diagnosed in that early time period to update our clinical care guidelines so that we can be learning from families who've been having these experiences and making sure that there's as much as possible guidance for the providers who will be caring for families, and that guidance can then be provided to our Duchenne and MDA networks. Okay, let's go to the next slide. Okay, so I keep referencing over the last 10 years. So this is just a quick snapshot of how we got here. I think it's important to say that we did not first start with newborn screening. We did actually try another path first. We actually, PPMD received a grant from CDC, and this was an effort actually led by Holly PA, but included all of the partners who work with children and pediatrics. It included MDA, and included the American Academy of Pediatrics, it included Centers for Disease Control, but it also very importantly included all the provider groups that work with young kids. So National Society for Genetic Counselors, the physician's assistants groups, the nurse practitioner groups. And then it included all the organizations that represented what we call differential diagnoses. So diagnoses that might be picked up at the same time within that 6 to 18 month time period that you might also be looking at a Duchenne diagnosis. So Cure SMA, the congenital muscular dystrophy community, the myotonic muscular dystrophy community. And we worked really hard to look at, was there another way in that 6 to 18 month time period to identify children earlier, and created a really wonderful diagnostic algorithm, tools for providers, tools for families. And all of that's available on childmuscleweakness.org if you're interested in looking at that. But what happened was, before we did this work, we had these surveillance information from CDC that had published that the diagnostic odyssey for Duchenne, as everyone knows here, was about 2 to 5 years from the time that a family first shared with their provider that they were concerned. Even after we did all this work, even after we pushed all these materials out, even after PAs and genetic counselors and nurse practitioners were pushing these materials into their own training programs, that statistic is still the same. So what we know is that the best way to reduce or eliminate the diagnostic odyssey and ensure that we can offer timely intervention to families with Duchenne is newborn screening. So that's why we moved to newborn screening efforts. So this next image in the center was where we started to build an infrastructure for a national Duchenne newborn screening system. So PPMD stood up a steering committee comprised of multiple working groups with partners from the broader newborn screening ecosystem, partners from all of the collaborative organizations who we worked with, partners from our Duchenne experts, to really understand what we would need to have a national infrastructure for Duchenne newborn screening and where were the gaps. So I just talked about the validated CK for Duchenne, that came out of that work. I talked about all of those provider materials, that came out of that work. And so much of that came out of that work. And then at one point we stopped and said, are we ready to move to a nomination to the federal uniform screening panel? And the answer was no. We had already had one early pilot in Ohio. Many of you know Jerry Mandel had led an Ohio pilot. But what we knew is that we needed to test this whole system. We needed to test this infrastructure and make sure we had still had it right and we really could serve a family. If a family was identified through newborn screening, did we have the follow-up system in place? So what we did was we conducted another pilot in a larger state in New York. And that is on the right-hand side, the New York State pilot. And what we needed to do was, again, test it. And we did. And we've conducted that New York State pilot. And we saw that we indeed had worked out some of the kinks. We now had the infrastructure in place to now move forward to a recommendation for a federal uniform screening system. So let's go to the next slide. I'm going to move swiftly through these because I've already talked through most of this. These are just timelines that sort of show you all the things I've already talked about. So when we started, Jerry Mandel conducted that Ohio pilot back in 2007. So we've been working on this for a very, very long time. And all of the different partners along the way who've led really critically important efforts. And so many funders. MDA funded a network through Ann Connolly to collect data on the developmental delays in our younger kids and toddlers. That data is critical right now. So all of these partner efforts are critical to moving this forward. So the next slide is more timeline and more effort that has really helped us get to where we are now. And so what I hope that you're seeing is that this has been a long, thoughtful, evidence-based process. And in the center of it all have been families who have really helped drive and lead this and helped us learn from the previous efforts, pilots that were conducted before. So with that, I think if we go to the next slide, these are all the partners, federal agencies, organizations, outside coalition partners, industry partners who've helped sponsor this. And the next slide are all the publications that have come out of this, because again, we need the evidence and we also need the guidelines. And I think that I hand off to Paul next. Speaking of partners, Paul, you're up.
All right, thank you very much, Annie, and good morning or good afternoon, everybody. I'm Paul Melmeyer. I'm the Executive Vice President of Public Policy and Advocacy at the Muscular Dystrophy Association. And as you can see, we've been a very long time partner in this endeavor to try to bring an earlier diagnosis and at this point now a newborn screen to the Duchenne community. What I'm going to be focusing on for just a few minutes is essentially where we're standing today with the federal effort, because you saw those decades of work that have gone into where we stand today. And right now we are in front of the ACHD&C, which stands for the Advisory Committee on Heritable Disorders in Newborns and Children, with the nomination of Duchenne to be added to the Federal Recommended Uniform Screening Panel. And as Annie already said, the Federal Recommended Uniform Screening Panel is incredibly important because while newborn screening is up to each state which disorders they actually screen for, and we'll get back to that key fact in a moment, the federal government actually recommending to states which screens should be included in their individual state panels is very important, as most states will want to listen to what the federal government has to say. So within the context of the ACH-DNC and within the recommended uniform screening panel, as Annie already said, we're all already somewhat through the process. PPMD has led the nomination, and we were very proud to co-sponsor that nomination in the summer of 2022. We then had a little bit of a bump in the road with a vote actually not to move the nomination to the next stage a few months thereafter, but thankfully in August of last year, the committee, the ACH-DNC, did vote to move our nomination onto the next stage, which then triggers a 9-month full evidence review at that time. So we are in that full evidence review period right now. And let me just tell you some of the main players that are involved within this effort. So of course, there's the ACH-DNC itself, and that's made up of experts who are very knowledgeable in newborn screening. Right now, at least according to the webpage that they operate, there are 13 members of this advisory committee, some of whom represents the federal agencies that are involved, and then 8, at least as of now, outside experts as well contributing their knowledge. And it is they who will eventually vote on whether to recommend to the Secretary of the Department of Health and Human Services whether to, for the federal government, to recommend Duchenne or any other condition for that matter to the states for them to screen. Now, the ACH-DNC listens very closely to a group called the Evidence-Based Review Group. This is an outside consultancy, if you will, that does a lot of the hard work, that does a lot of the dig, and they're the ones who are going to read all those studies that Annie had on the previous slide, and then come back to this advisory committee and say, this is what we found. These are the key points that would support screening for Duchenne. These are the key points that might not support screening for Duchenne. At the same time, there's a technical expert panel that is kind of outside experts who are very knowledgeable in Duchenne, and we're very grateful that someone from MDA is on that, as is someone from PPMD and many other individuals who are advising the ACH-DNC and the expert-based review group, or the evidence-based review group, excuse me, on Duchenne. And then there's us, the nominators. That's PPMD leading the way with MDA joining as well. So there is actually a big meeting next week. It's a week from yesterday, technically. It starts on May 9th, continues on to May 10th. And at this meeting, this is the 9-month mark from when we had initially moved the Duchenne nomination onto the full evidence review stage. And according to law, the ACH-DNC actually has to vote at that point. That's in the law. They have to vote on something. And so we're at that 9-month mark. And that's very exciting because that means for the last 9 months, the evidence-based review group has been working hard to bring their recommendations, their analysis to the ACH-DNC to then tell them that this is what's important to know about Duchenne and potentially adding Duchenne to the recommended uniform screening panel prior to the secretary from there taking that recommendation. But that's actually not what's going to be happening on May 9th in particular. That might be what typically would happen on May 9th, but not this time around. And that's because this time around, actually within the last month or two, we in PPMD have asked the committee to actually delay that vote. And that might not really seem like the right thing to do, perhaps just right off the bat of why would we want to delay a vote on our newborn screening nomination for Duchenne? Well, the reason is because over the next little while, there's going to be some really, really important data and evidence that is going to be published. It's not published yet, but will be published hopefully within the next little while that will only strengthen our arguments for why Duchenne should be added to the recommended uniform screening panel. And I think we can actually move to the next slide with that. So this is the reason for why we requested a delay, because we feel very confident about the package as it rests today. We think that the evidence is there and that Duchenne, of course, should be added to the recommended uniform screening panel. But just to be 100% sure that we're putting really our best foot forward, that we're giving them every single piece of evidence that they want to see that we can possibly give them, this is the reason for why we wrote to the committee just a month or two ago and said, let's delay the process just a bit. Now, the committee meets every 3 months. They're scheduled to meet again in August. They're then scheduled to meet again in November. What we're expecting for next week, the committee may vote to delay till August. They might just vote to delay in general. We can't necessarily predict the future, but we do expect them to delay at least by 3 months. And then over the course of the next 3 and maybe 6 months for that matter, it might be actually until November, in which the committee does have this full vote on recommending Duchenne to the recommended uniform screening panel. During that time, we're going to be offering the committee and the evidence review group even more data than what we've already offered them. And I'll tell you what we're going to be especially emphasizing. What we're going to be especially emphasizing is the early effectiveness of the use of steroids, because we have decades of data on the use of steroids in Duchenne. And what the committee wants to see is that if a diagnosis happens earlier for a child with Duchenne, that the administration of a therapy, in this case would be steroids, would lead to better health outcomes for that child than if they were administered steroids at a later date. And then kind of on the other side of the coin, if a child was administered steroids later than when children with Duchenne are oftentimes administered steroids, that actually resulted in poorer health outcomes, unfortunately, than if they had been administered steroids at the more standard time in which steroids may start. So that's the kind of data that we're going to be providing to the committee. And we're also going to be looking closely at whether the label for ELEVIDYS will be expanded this summer. We all know that might be the case. We'll also be collecting additional data that's in the works right now that we know is out there, handing it over to the evidence-based review group so they can then recommend to the ACHD and see what we're hoping to be a positive recommendation to move forward with Duchenne later this year, not August, potentially November. But that is certainly what we're hoping for. So if for those of you who are tuning in next Thursday, you'll see me giving testimony, you'll see Lauren giving testimony on these topics. You'll see other Duchenne experts as well as families giving testimony on why Duchenne should be added to the recommended uniform screening panel. So join us listening in, if you will, next Thursday. The conversation's actually going to be in the morning. We'll be testifying at 10 a.m. Eastern time. Conversation, I believe, is at either noon or 1 o'clock Eastern time, so just in the early afternoon. But you'll see most of what I'm saying here play out. And then, of course, we'll update you all as the effort continues from there. So I think with that, I can pause. And Annie, I think I might be handing it back to you.
Excellent. So one of the things that I have the privilege of getting to do now in my current role with the EveryLife Foundation is we lead an effort called RUSP alignment legislation. And so as Paul just referenced, there is the federal recommended uniform screening panel. I want to make sure we touch on all the letters in the acronym, or the RUSP. And that is at the end of this process with Duchenne, what we hope Duchenne is added to is that federal panel. And that is a list of conditions that the Secretary of Health and Human Services has recommended states screen for. But then there is another process wherein each state then determines which conditions they screen for within their state. And those determinations are made by each state based on the resources within their state, their capacity within the lab to conduct the screening, whether it requires new technology for them to do the screen, their ability to turn that screen around within the recommended time. There are a lot of factors that are considered within a state that might limit their ability to screen for a condition or to add a condition to their panel. So one of the things that we have been doing at the EveryLife Foundation is to try and align the conditions that states screen for with the conditions that are recommended federally. Because a significant problem, as you can imagine, is the disparity from state to state. So for example, I'm in the DC area, so I live in Maryland. And where I live in Maryland, it is not uncommon that somebody could live and work in Washington, D.C., but deliver a baby in Virginia. And if you live in one area, in D.C., for example, and you deliver your baby in Virginia, the condition that if I went into labor while I was at work in D.C. and ended up delivering my baby in Washington, the conditions that my child would be screened for in that hospital in Washington are different than the conditions my baby would be screened for at home in Virginia, and are different than the conditions my baby would be screened for in Maryland. So a difference of 2 miles makes a very large difference in the conditions your child might be screened for, identified, and ultimately receive life-saving treatment for. And that is a circumstance that we refer to in the rare disease community as death by zip code. So what we work on at EveryLife and with our partners here is aligning the RUSP with the state implementation, because it can take up to a decade to have conditions that are on the federal panel added to state panels. So what you see there are those black dots that Lauren created this nice map that shows you the states where we've passed RUSP alignment legislation. And what's important for this conversation is to say that RUSP alignment legislation requires we go in and we work with the states and we understand what those states need as far as resources, as far as legislative support. Each state operates differently with their state labs. Each state has different authorities. We look at the conditions that are moving through process. And the other thing is, in our state legislation, we don't name conditions. So we don't have specific conditions in our RUSP alignment bills. What we say in the legislation is that any condition that has met the evidentiary requirements for the federal panel has a required timeline, and each state is a little different, but usually it's about 2 years, to then be added to the RUSP. And then we have worked with each individual state to determine what the resources based on the state lab fees are in order for them to meet those timelines for the alignment. So we are very proud to say that as of last week, when Tennessee was added, right now, 49.7% of babies born in the US are born in RUSP aligned states. So we show you this map to say that we've been working very closely with PPMD and our partners at MDA and Little Hercules to develop a strategy for which states PPMD and MDA and Little Hercules will start to work with on state legislative efforts, so that there's sort of low-hanging fruit, and then there are the states that already will be poised and ready with RUSP alignment once there's a federal recommendation made. So I'm going to hand it, I believe, to Jill.
Actually, sorry, Annie, I'm going to talk quickly about this and then I'll pass it over to Jill. Sorry. So thank you for all that background, Paul and Annie. Paul had mentioned that you can virtually come to the ACHDNC meeting. We created this nice little scan thing for you guys. It'll bring you right to the registration page if you'd like to join. We're also going to send out an email following this with links to things. So we will send this out, but I just wanted to let you guys know we checked with our friends over at the ACHDNC, and you can register for the meeting up until the day of the meeting. So that's just a nice little box if you want to scan that with your phone to bring you to the registration page. We'd love to have folks there. As Paul mentioned, he and I are both testifying. We have some doctors, we have some families. So it should be good. And we gave you a little background on where we are in newborn screening and all of that. So now Jill and I are going to talk a little more to how you can get involved and how you can help us out with our efforts. So with that, now I'll pass it over to Jill.
Okay, hi, thanks everybody. I'm Jill Castle, and in case you're new and do not know me, I've been in the Duchenne space for over 20 years in one capacity or another. I'm currently working with Little Hercules as their Director of Education and Patient Services. I want to give you a little bit update on the states that are taking action right now. They've begun the process independent of the RUSP situation. So Arizona, I'll go first because that's my state. So we have passed the Senate and the House, and we are now in the Budget Committee, and it looks good. We have a lot of support. It's like hurry up and wait. We don't know how long that's going to take. But once it's done and goes through budget, it'll go to the governor's office, and we've already rallied some support from the governor. So Arizona looks good and on track. Illinois right now is in the Health and Human Services for House Appropriations, and they're looking at their fiscal note, which is what Annie explained, where you put in the lab fees and some of the other costs to add. It's called a fiscal note, and then that's where the appropriation committees look at the numbers, and they work with Department of Health Services to make sure everything's aligned and the state can afford it in the budget process. Connecticut, they've got great support there. They passed the health committee and they went on to appropriations and attached that fiscal note. But since they're in the middle of a 2-year session, the rep is going to reintroduce it next year. It's been paused due to budget, but they've got a lot of support. So that bill looks good too. In California, it passed out of the health committee and it's now going to appropriations and getting the fiscal note attached. And that will hopefully be heard next week. So we'll know more on that. And Indiana just submitted their application to their committee, which is what I'm going to talk about right now. So each state, like Annie, I think everybody alluded to the fact that some states are primed for this and some states aren't. Some states are better to wait, and there's different reasons. It's very complicated, as everybody's explained. And the process from state to state varies. So each state decides which conditions it's going to add in addition to the federal. And it's a different process. So in some states, for example, they add it via legislation. And some states, they have an advisory council that reviews and decides whether to make recommendation for it or not. Some states do both of those processes. And then some have a regulatory process via the Department of Health. And then some states just wait for the RUSP alignment to take place. So there's various ways, and it gets very complicated. So one of the initiatives that we're working on right now is offering you support. So if you're interested in working in your state, we're running a group at Little Hercules where we talk to you about your state. We talk about the complications of picking the right sponsor. I mean, if you don't pick the right sponsor, a bill could be dead and not welcomed because of the person that's sponsoring it. So it gets a lot more complicated, which, you know, I started learning, and that's how this group got started, was to just educate everybody and get everybody on the same page. We will also educate you on your state process, whether it's legislation or whether it's committee, and how that's going to go and who the right players are in your state, who you want to make friends with to make this the best possible scenario and give the bill the best chance. We'll talk to you more and educate you on the fiscal note. If you're an advocate in your state, it becomes very helpful that you talk to different players in the state and prep them. And a lot of these relationships take a lot of time to cultivate. Like sometimes, you know, maybe your state isn't primed for this right now, but it will be. And so what we want to do is work with you to put you in touch with the best people in the state that you want to start making friends with, so that when that opportunity arises, you're aligned for that. We will coach people on testimony if they're asked to provide testimony. We've got samples. We've got people in the group that will share their stories and offer support. And we have letters. We have coalition letters, and we have letters that are signed by advocacy groups that will be helpful. Some people are really great at testimony. Some people end up being better at meeting with people and writing letters. So there's kind of a place for all advocacy. And then what we're doing lastly is, if for any reason it's not the optimal time for your state, and we explain all that and we talk about that, again, we would help you to start establishing relationships for that, and also redirect you to other advocacy. You know, sometimes in the states, there's other things you can do by adding a rare disease advisory council or other initiatives in the state that you could start and make friends in your state so that you're in alignment and ready to go when it is the appropriate timing for you to potentially add testimony for the newborn screening. So I think that's all I got, but we're gonna, Lauren is gonna give out a Google link where you'll be able to sign up if you're interested in working in advocacy in your state, and then we will reach out and we will invite you to our group and we'll start working together. I think that's my part. Yep.
Thank you, Jill. So I think that covers most of the background on everything that's going on right now. As you can probably already tell, the next RUSP meeting, which will be in August, we're really gonna we're gonna start asking folks to submit comments when August comes around in support of our package. So we're gonna ask for help with that. I'll have more steps for you as it gets closer to the August meeting. So we're gonna send around, or for the next, we can go to the next slide, I guess. And then Stephanie, if you want to send the link to the Google form too, that would be really helpful. So in this Google form, you can fill out if you're interested in helping us with the federal or state level work that we're doing. And then Jill and I will reach out to you about next steps and how strategic and what states that we're doing state focused work in right now. And sorry, it says my internet's unstable. I hope I'm not breaking up. We're being very strategic in what states that we're doing in. So we really want to work in collaboration and coordination with you. And if right now your state isn't a state that we're focused in, it's not because we don't want newborn screening to be there. It's just we're being really careful and thoughtful about where we go and what we're doing. So just keep that in mind when we chat with you. So I think that's everything. Please fill out the Google form if you want to help us out. We're really trying to, like Jill mentioned, rally the troops and get everything set up for the coming months, especially the August ACHDNC meeting. And then the state work, I feel like, is happening all the time. So more on a rolling basis. So we really want to reach out and we want to have folks ready for that. I think that's all we have for our program. So does anyone have any questions? I see there's one, Annie, if you want to help us with this one. I see one that says, how many hours after the baby is born must the blood sample be taken?
It has to be taken over 24 hours after the baby is born in order not to have a falsely elevated CK because of birth trauma. And then, so the window is 24 to 48 hours for that reason.
Okay. And if anyone has any other questions, you can feel free to raise your hand or put them in the chat. Okay.
I see a question about which neuromuscular physicians are getting the referrals. How is that decided? So this is a public health program. We don't get to control that. So what we did get to do, though, is a part of this. So as a part of the public health program, there is something called ACT sheets or action sheets, and they're developed by the American Academy or the American College of Medical Genetics. And so an ACT sheet was developed, or actually there had already been one for Duchenne, believe it or not, but it was incredibly outdated and had a lot of not amazing information in it. And so as a part of the pilot effort, we developed an updated ACT sheet or action sheet that all state health departments will have. So it is a part of that algorithm of what happens next when there's an out of range result. And that is available to the state health departments and then also is available to primary providers. And that includes information about the neuromuscular clinics. It includes information about MDA and PPMD. And so it's really up to those providers to then seek out those resources, but those links are available to them to take them to those clinical networks.
Okay, the next question is, will some female carriers be identified through newborn screening?
So during the pilot, we can tell you the reason why we went for whole population screening is because as we roll out newborn screening, we've learned so much more about our Duchenne community. And during the pilot, we did identify some infants who were above range, had out of range results above the threshold who were female.
Thank you. Any other questions? I can see I have the form filled up and people are already filling out the interest form, so that's really exciting. Oh, okay. This one, how do first-time parents find out about newborn screening and what is on the panel? Annie, you want to take that one too?
Yeah, I mean, I can say like most of us, you probably don't even know that you're having newborn screening when you have your baby in a health system. So it's just one of the things that happens. Maybe you were told when you were going to see the OB/GYN. I think that's something that we talk as a community, a newborn screening community, that we need to do a better job working with the OBs, making sure that parents know proactively what happens in the hospital. But it's something that happens now. Everybody here had newborn screening if you had a baby. It's just Duchenne wasn't one of the things screened for. So what we are wanting to do is add Duchenne to the newborn screening panel. The question of how we do a better job of making sure people are aware that newborn screening is happening is a really important conversation for us to be having with that sector of the community, the clinical community that works with birth parents.
Annie, do you have any information on if families can opt out?
Again, that would be a really good conversation for the genetics and OBGYN community. If families have a religious objection or concerns about anything that might be happening as a part of their birthing process. But this is a public health program. So there are families that opt out of other elements of the public health system and public health programs. This would go into that category.
And I see that there was there are questions about, I know we've received some questions before this about things that are happening in specific states. I will reach out individually to respond to those questions about specific states. The results from the New York pilot.
We've published those
Yeah.
and they're available. I should say we, PPMD and MDA and Nikki Armstrong, who did a lot of the heavy lifting. I was just grateful to get to be a part of it. I'm just faster at answering the questions off.
Are there any other questions? No?
I just want to, first of all, I want to thank everybody, MDA and PPMD and Little Hercules and everybody for doing this today. I just have to say this has been a very long time coming. And I just want to also thank, I don't even know if they're watching today, but we've had a steering committee that has included really phenomenal leaders from our clinical community and most importantly, our patient community who have been a part of this for a very long journey with us. And we are very grateful to those who have made this possible and who have shared their experiences, some within newborn screening and those original pilots in Pennsylvania and Ohio a very long time ago. And we have learned from their experiences and tried to improve upon those experiences so that we can ensure that those who are served through newborn screening and have opportunities to have more timely diagnoses and more timely interventions in Duchenne benefit from all of those who are in this ecosystem now. And so I just say on behalf of all of us here, if you as families, in addition to helping us have conditions added to state panels, have suggestions as to how we ensure that we have services and programs for families who will be entering this community at earlier stages than most had previously. These organizations, we are all open to ideas as to how we ensure that we welcome families with open arms and we make sure that we have programming that is tailored to this, a new segment of a community that will be coming in and joining us.
Thank you, Annie. And we had another question come in, which I can answer, and then Paul, you can chime in too if I miss anything. So the question is the August vote the last chance? What happens if the vote is negative? So we, meaning MDA and PPMD, will have to decide probably around mid-June if we want the vote, if we think all of the data that we're waiting on right now is clearly ready for the August vote, because they need about 6 weeks to review the data from the time they get it till when the vote is. So mid-June, around then, we will have to make a decision on if we want to push for another delay to November. The November date would be that is the furthest or the last time we could delay it. So then the latest they can vote on it is November. They could vote on it in August, depending on when the status of that data. They might end up voting on it in November. If a no vote happens, then we would have to work on resubmitting our package in the future. So then, yes, it's the end of it for that now, but it won't be the end of our efforts. That's absolutely not, we won't just say, okay, they voted no, we're done, we're moving on. But they do have to vote in November, regardless, even if we were like, please, another delay, no, they have to vote on if it gets added in November. I don't know, Paul, if you have anything to add to that.
Yeah, that was pretty spot on, Lauren. The only thing I would add is that if there is a negative vote in August or November, not only is the committee looking for ways to kind of expedite the renomination process, that's been part of the conversation in the committee of late, but there's actually an example recently of the Crab A committee or Crab A community receiving a negative vote from the committee. And then actually pretty shortly thereafter, I think at about a year or so thereafter, they received the positive vote because enough additional evidence or data or conversation was had so that the committee only about a year thereafter voted positively towards recommending the Crab A to the secretary for the RUSP. So if there is a negative vote, certainly not the end of the process, and it would potentially extend us just a little ways down the road of getting another vote thereafter.
Yeah, and I think just to add on to what Paul just said, he's spot on about the Crab A experience and some of that additional evidence that was so critical for Crab A to receive the positive outcome of their second nomination was state data. So the Crab A community had statewide data from programs and states where they had the condition implemented already that they could then bring before the committee. So that really goes back to what we talked about in the second portion of this webinar, is that the fact that we now do have states starting to collect statewide data beyond just the pilots that we had earlier conducted, there is a benefit to having some time pass and then having some of that data that we can then bring forward should we need to do that.
And the last thing I'll add for that too is I think Paul and I are very grateful. We have a pretty clear line of communication with the ACHDNC committee and our folks that work there. So they want to help us and we want to help them and all of that. So it's a good working relationship. And I think if it were to be a no vote in November, they would want to help us strengthen our package after that, which hopefully it's not, and we won't have, this will be non-issues that we're talking about. But I think unless anyone else has any other questions, I think we can wrap. Thank you so much, everyone, for coming, and look for the follow-up email from me coming shortly. And we really appreciate you all. And thank you to our panelists for joining us. I think it was a great conversation, and we look forward to working with you guys to get this across the finish line.